Okay, first I just want to say thank you so much for having me here today. I'm delighted to be participating in this conference. And let me share my screen. So I'm going to talk about how to successfully treat body dysmorphic disorder, BDD, with medication. I think we all know that BDD is a very challenging condition. It causes a lot of suffering. It can really diminish the quality of people's lives. The really good news is that we have very effective treatments for body dysmorphic disorder. One of them is cognitive behavioral therapy, which you're hearing about from other speakers today. One of them is medication. Now, most patients who try medication don't get quite the right medication or the right dose, and those details are very important. So what I'm going to do today is give you an overview of how to successfully treat body dysmorphic disorder with medication, and most people can get better with the right medication. So I'm not sure, let me see, I can't get my slides to go forward. Oh, there I got it to do that. All right, first my disclosures. So just briefly, what is body dysmorphic disorder? I think you all know what it is, but people with BDD see themselves differently than others see them. They see themselves as ugly, abnormal, unattractive, deformed. They may use a whole range of negative terms. And most people with BDD are completely or mostly certain that they really look ugly, even though they don't to other people, even though their flaws are actually minimal or non-existent in the eyes of others. And this is probably because their brains are actually seeing something different than what other people are seeing. And then in addition, people with body dysmorphic disorder are preoccupied with their perceived ugliness, which causes significant emotional distress and or interferes with day-to-day functioning, usually both. And I circle this one because this is very important. It's a very important component. It's sort of the core component of how we define BDD. So really for people to have this diagnosis, they need to have the preoccupation, which typically takes 5 to 8 hours a day, but typically at least an hour a day, thinking very negative thoughts about their appearance, and in addition, significant emotional distress or interference with functioning. This helps us differentiate BDD from very common appearance dissatisfaction, which may not necessarily cause preoccupation, distress, or interference in functioning. And then in addition, people with BDD perform repetitive behaviors in response to the appearance concerns. For example, mirror checking, comparing with others, compulsive grooming, skin picking, reassurance seeking, and you can see some of these behaviors in this photograph. So what is BDD not? BDD is certainly not vanity, and I think in the early days of BDD, 3 decades ago, this was a common misconception. It was so unfortunate. I think that's really changed as researchers have learned that there are brain-based aberrations in visual processing in people with BDD. It's not vanity. It's a serious mental health condition. It's not anyone's fault. As I mentioned previously, it's not simply appearance dissatisfaction, which is so common. Most people have some dissatisfaction with some aspect of their appearance, but again, you need the preoccupation that is causing significant distress or impairment in functioning to get a diagnosis of BDD. BDD is not just an adolescent phase. In fact, BDD most often starts during adolescence, so you have to be really careful with adolescents and not just write off their concerns as, oh, this is something all adolescents do. They may have BDD, and if so, it needs to be treated. And BDD is certainly not trivial. So why should we recognize and treat BDD? For so many reasons. For one, it's common. It's more common than obsessive compulsive disorder, than anorexia nervosa, than schizophrenia, than bipolar 1 or bipolar 2 disorder, etc. And it currently affects about close to 2% to close to 3% of the general population. So worldwide, that translates into a large number of people. And BDD causes tremendous suffering and impairment in day-to-day functioning. It is associated with very high rates of suicidality, and recent studies suggest that these rates may be higher than in most other psychiatric disorders. And BDD usually improves with the right treatment. So this is the very good news. We have really good treatments for BDD. So here are my recommended treatments for BDD. For mild BDD, I recommend CBT as a first-line treatment. It needs to be tailored to BDD specifically. I think medication is also very reasonable if the patient has comorbidities, co-occurring conditions that may improve with medication, like depression or OCD or social anxiety disorder, etc. If CBT is not available, or if the person prefers medication. For moderate BDD, I recommend medication and or CBT, either or both, and it's really a personal choice that you would want to discuss with your clinician. For severe BDD, I always recommend both medication and CBT. You always need medication with more concerning degrees of suicidality because these medications improve suicidality, and you need to consider a higher level of care. In other words, more intensive treatment, maybe inpatient treatment, for example. So I'm going to focus on medication in this talk. As I mentioned, medication helps most people with BDD, but for medication to work, you need a few things. You need the right medication, you need the right dose, you need a long enough trial, and you need good adherence. That means never missing any doses. If you miss even 1 or 2 doses a week, the medicine may not work for you. Unfortunately, we have found in several research studies that most medication trials for BDD are not adequate. Not all of these are present, and so then people conclude that medicine doesn't work. I think the problem probably was that one of these ingredients was not present. So the SRIs are the first-line medications for BDD, sometimes called SRIs, sometimes called SSRIs. These are abbreviations for serotonin reuptake inhibitors. Some of them are selective serotonin reuptake inhibitors. They're often effective. And when they work, they decrease BDD obsessions. They give people more control over their thinking. The intrusive negative BDD thoughts like I'm ugly or people are laughing at me just don't come into the person's mind as often, and it's easier to redirect their attention to other less distressing thoughts. The repetitive behaviors the urges are not as strong. The person doesn't feel compelled to do them as often. And when the urges do come, the person usually has much more control over these behaviors and often can stop them completely. The medications typically alleviate BDD-related distress, depression, anger and irritability, anxiety. They often improve insight. Often people develop a more accurate view of their body image, recognizing that they don't look ugly or deformed in some way. Functioning and quality of life often improve. They're usually well tolerated. Very few people have to stop these medications because of side effects, and I'll talk more about that later. And what's nice is they're very broad spectrum. They're also often effective for many other conditions. There are first-line medication for OCD, for depression. They often are effective for binge eating disorder, bulimia, anxiety disorder. So, if you have one of these conditions in addition to BDD, that's a nice advantage of trying one of these medications. So there are quite a few SRIs. There's 7 of them actually. And they're a little confusing because they have both generic names, which are used across all countries, and then they have brand names, and some brand names are used in some countries and others used in other countries. So all these medications have 2 different names, or more than 2, as you can see here, but they all have the same generic name around the world. I usually prescribe one of these. All of the SRIs are probably equally effective. We don't have studies in BDD that have compared one to one another, but I tend to prefer these. I've used them for decades in so many patients, and I just find in terms of tolerability and effectiveness, I often start with one of these 3. There's also fluvoxamine, many brand names. Clomipramine. This is a little different from some of the others. It's still an SRI. I think it's a good option if several of these haven't worked. It may be more likely to have side effects, so we don't typically start with it, but it certainly is an excellent medication. There's also paroxetine and citalopram. Now, I think this is the least good choice in the United States because the regulatory agency in the US that oversees prescription meds in recent years put a pretty firm limit on the maximum dose, and it's often too low for BDD. Those maximum doses that are developed by the regulatory agencies in different countries, those maximum doses can differ somewhat in different countries. And it's not because the medications are different in different countries, it's just that the regulatory agencies may have decided for whatever reason to come up with a slightly different maximum dose, which we can exceed for most of these SRIs, as I will talk about later. But I think in the US, the dosing limit is fairly firm. It's pretty low, often too low for BDD, but it's okay because citalopram is very similar to escitalopram. They're almost the same medication, and we don't have that firmer dosing limit in the US for escitalopram, so we can use that one instead. So how do we know that these medications work? Well, back in the late 80s and the early 90s when I started doing my scientific studies in BDD and started treating patients, we didn't know how to treat BDD. That's hard to believe because BDD has existed, at least we have case reports for centuries, and it probably goes back millennia. And we didn't know how to treat it, even as recently as the early 90s. So Dr. Eric Hollander and I just started treating patients in our clinical practice. SRIs had just become available. It made sense to use them because they're great antidepressants. We knew they worked for OCD, and there are many similarities between BDD and OCD. So just in our clinical practices, we found that the SRIs were more effective than a whole range of other medications. That then led to more rigorous open-label treatment studies. Now, they don't have placebo, but they're rigorous in how they're done. And fluvoxamine, 2 studies were done, one with citalopram, one with escitalopram, and you can see nice high response rates after maybe 12 to 16 weeks with one of these medications. Now, these response rates are based on what are called intention to treat analyses. So this includes all patients who took even 1 dose of medicine, and you know 1 dose of medicine isn't going to work. And so if they dropped out of the study after 1 dose of medicine, their data were still included. And so, if you include early dropouts, your numbers aren't going to look as good because they haven't had enough time on the medicine for it to work in some cases. So I mention that because if you look only at all the participants who completed the whole medication trial, these percentages are higher. And they're higher in clinical practice because we can exceed, for most of the SRIs, we can exceed the doses that we used in these studies. It's often safe, and it often makes the medicines work better. And also we can add other medicines in to an SRI if it doesn't work well enough in clinical practice. So I think in the real world we can get even better numbers than these. And these are pretty good. And this is just for a single trial. Dr. Eric Hollander then did a really wonderful controlled crossover trials. This is a rigorous study comparing the SRI clomipramine to the non-SRI antidepressant dizipramine. And neither the patients nor the doctors knew what medication they were getting. And the SRI clomipramine was more effective than this other antidepressant. So very much like OCD, and indicating that it's the serotonergic, it's the SRI forms of antidepressants that we need for BDD. And then, this is a gold standard study design, a placebo-controlled trial that I did of fluoxetine versus placebo. Fluoxetine was more efficacious. And then a placebo-controlled relapse prevention trial. This is a little bit more complicated, but 100 people were first treated with escitalopram, and then those who responded to the medication were randomly assigned to continue the escitalopram or switch over to a sugar pill, to placebo. And those who continued on the escitalopram did better over the next 6 months. So continuing the escitalopram protected against relapse. And in fact, many people in that group, in the medication group, kept getting better and better and better beyond the initial 3 to 4 months of the initial escitalopram. And here's the fluoxetine versus placebo trial. So you can see BDD severity score here. And then over 12 weeks, you can see that the scores came down much more for those on the medication than for those on the sugar pill. So my usual first-line approach when I treat patients with BDD, I start with an SSRI. We have much better data for the SSRIs than for other medications, and I think the SSRIs are often better tolerated than other medications that people sometimes get. I try to reach the maximum SSRI dose, that's the maximum approved by the regulatory agency, the FDA in the United States, within 5 to 10 weeks. But I go a little higher for escitalopram, 30 milligrams a day, because I think that maximum, the regulatory maximum dose is too low relative to the other SRIs. And I do this if the medication is tolerated. It usually is, but if you get side effects, you're not going to go quite this fast. And if a low dose is starting to work, then you don't have to keep raising the dose. You can keep it at a lower dose and just give it a little bit more time and see if that lower dose will work well enough, and maybe it will. So not everyone has to get up to a high dose. Clomipramine is a little bit different. That dosing is guided by blood levels. For younger youth and the elderly, I usually start with a somewhat lower dose, and I may raise it a little bit more slowly, and I may not reach as high a dose. And to see if an SRI is going to work, you want a trial duration of 12 to 14 weeks, with about 4 of those weeks on the maximum dose approved by the regulators in your country. But again, for 30 milligrams a day for escitalopram, and taking it every day. And again, if you start to get better within those 12 to 14 weeks, you may not have to go up to that maximum dose. So dosing for BDD, here are the medications. Here are the maximum doses in the United States. Again, they're probably fairly similar in different countries, but you may find a few differences. These are the maximum approved doses. And these are how high we go for BDD, so look how much higher, and it's really okay for most of these medications. Most of these medications have what we call a high therapeutic index. You go a little bit above the dose, nothing bad happens. I do get an EKG at higher doses. This is a painless, quick assessment of your heart's electrical rhythm. It takes about a minute and no pain involved. But you can see how much higher these doses are. I think most of these doses really were approved for disorders like depression, which tend not to need as high doses as the obsessional disorders like BDD and OCD. And these doses are also sometimes used for OCD. They are sanctioned by a number of so-called practice guidelines, including a practice guideline for OCD from the American Psychiatric Association. I would note that we do not exceed 250 for clomipramine, and as I mentioned, we kind of come up with that dose by monitoring blood levels. And this revised citalopram dose of 40 down at the bottom, yeah, I consider this pretty firm, and I tend not to exceed that, and I don't use this medication anymore for that reason. But again, escitalopram is almost the same. What we're lacking in BDD is studies that randomly assign people to different doses. The only average dose, or the only dosing information that I know of, is from my own clinical practice from over the past 30 years or so, where I have looked at the average dose that I have used to get people better with BDD. Now, for escitalopram, you can see I more recently have started using higher doses, and what the plus minus means is this is a standard deviation. So if you take 45 minus 15, that's 30. If you do 45 plus 15, that's 60. So what this means is about 2/3 of patients who I have treated have needed between 30 and 60 milligrams a day. So it's plus minus, this is the average, plus minus this number, and about 2/3 are within that range. You can see I used to use pretty high doses of citalopram, and 40 is not enough for most people. Again, why I don't use it anymore. And you can check, we do check EKGs on a higher dose of escitalopram with clomipramine, and you can if you get to higher doses of the SSRIs if you want to. I sometimes do and sometimes don't. Now, what if an SSRI doesn't help enough? Well, the first thing is to make sure it's taken every day, because it's so easy to forget. And so often with my patients, we work very hard on how to remember to take the medicine every day and maybe use a pill box or an alarm or an app. That's the first thing, because sometimes people aren't feeling well enough, but once they start taking the medicine every day, they really feel better, and you don't really have to do anything else other than take it every day. If that doesn't work, my first choice is to increase the SSRI dose if the person's tolerating it well, not having problematic side effects, which is the norm. And so I'm showing you the same slide again just to remind you of these maximum doses. You can also, if these approaches don't work, you can also augment the SSRI. You can add another medication to the SSRI. And this is kind of an evolving field. You know, we're always learning new things about BDD. We're always finding new medications that may be helpful when added to an SRI. So there is a group of medications called Neuroleptics. They're sometimes referred to as antipsychotics. They are good for psychotic symptoms, but increasingly they're referred to as mental health medications, which is a very broad term. And it reflects the fact that these medications treat so many different kinds of symptoms. The term antipsychotic is too narrow. You know, they treat bipolar disorder, they treat depression, they treat OCD, they treat so many conditions, sometimes by themselves, sometimes when added on to something like an SRI. So I did a study long ago of one of these medications, which had been shown to work in OCD, Pimozide. This is a typical or an older neuroleptic. And what I did is I added either Pimozide or placebo to the SRI fluoxetine in patients who had not had a good enough response to the SRI fluoxetine. And the Pimozide didn't help. I and another research group then did some chart review studies. Those are tough. It's tough to draw many deductions from chart review studies because patients, you look back through your records and what did have the patients do with medications, but often there are multiple medication changes at once, or you're adding or stopping therapy, and so it's a little hard to draw firm conclusions from those studies, and it sort of had equivocal results about how well these medications work for BDD. But what I would say is we have a lot of clinical experience and clinical consensus, not good studies, but really broad consensus that the atypical neuroleptics, these are the newer neuroleptics as opposed to the typical or older ones. The newer ones can be very helpful when added to an SRI for BDD. My favorite is aripiprazole. It is often very helpful when added to an SRI if an SRI alone isn't necessary. I sometimes will use lorazepam. I tend to use the newer ones that are better tolerated, usually very well tolerated. And you can add to an SRI after you finish the SRI trial, after that 12 to 14 weeks, if improvement is inadequate, you've gotten the dose up as high as you can go with it. And I think especially if the person still has moderate to severe depression, moderate to severe BDD or OCD, it's a good choice relative to a few I'll show you on the next slide. But sometimes I use something like aripiprazole earlier during an SRI trial, especially if the person has very severe symptoms, like severe depression, worrisome hostility or aggressive behavior, severe agitation or worrisome suicidality. I mean, the SRIs typically work very well, but sometimes I want to increase the odds of a greater degree of improvement and more rapid improvement by adding Abilify, aripiprazole early on in treatment, because sometimes it works within a few days. It's incredible. Not always. Maybe in 25% of people you can see pretty dramatic improvement within 3 to 4 days of starting it. I usually start with a low dose, very low dose, like 1 milligram of aripiprazole, and then in a few days going up to 2 milligrams. You can dose it up to 30 a day, so that's a very low dose because I want to minimize possible side effects and make sure people can tolerate this medication well, and they usually do. Other medicines that you can add on to an SRI, if an SRI alone is not adequate for improving BDD symptoms, buspirone is a nice, benign anti-anxiety medication. It can also help depression if you add it to an SRI. And BDD improves in maybe 30 to 40% of people. Anxiety can get better. Depression sometimes gets better. Average dose of 50 to 60 a day. That's on the higher side, but that's fine. People tolerate it very well in most cases. It's not habit-forming as some other anti-anxiety medicines are, and it's usually very well tolerated. I rarely see side effects with buspirone. And then some newer medications, which are also being tried in OCD, and we have a few promising studies in OCD with glutamate modulators. It's an area of active interest in research, especially in OCD. And I put a question mark here because we don't have studies in BDD, but I am using them in part because they're very benign. Most people tolerate them very well, and some people really get better when they are added to an SRI. I would not use them alone. So one is N-acetylcysteine, NAC. This is a supplement, a nutraceutical that you don't need a prescription for. And I find sometimes lower doses are helpful, especially for skin picking, but I generally find patients need up to 1,200 and sometimes up to 1,800 milligrams twice a day. Memantine, 10 milligrams twice a day. And there are some others in this category. I usually use one of these if I'm going to use them, or both, because they are very well tolerated and so easy to prescribe. And they can often be quite helpful for BDD and for OCD, in my experience. So we've gone through all of these options. So our last option is to switch if one SRI doesn't work. If you've made sure you have good adherence, you've tried raising the dose, you've augmented, then you always have the option of switching to something else, because we do have 7 of these medications. So my first choice is to switch to another SSRI. This is what we do in OCD also. One may work better than another for you, and there's no way to predict which one is going to work best. Now, when I did a chart review study of patients I had treated in my clinical practice, we found that about 44% of people did well with this approach. But I think actually it's higher than that, because I think now, I did this study, I don't know, back in the early 2000s, now we have better augmentation strategies. So, if the SRI alone doesn't work well enough, you can augment it with another medication or with CBT. We know so much more about what effective CBT consists of. So I think our response rates are better now than back when I did this study. And if several SSRIs haven't helped, try the SRI clomipramine. It has a tendency to have more side effects, but most people do not get troubling side effects. And it is a little different than the SSRI, so it's worth trying. Then you can consider other medications, and these 3 all boost serotonin in the brain. They normalize serotonin. And that's what we're trying to do when we use an SSRI. So venlafaxine, there was a positive study in BDD, not a rigorous placebo-controlled study, but it did show that it was often helpful. I tend to use, if needed, up to 450 milligrams a day. Another SNRI, so these are serotonin norepinephrine reuptake inhibitors. They do boost serotonin. We have no studies in BDD, but I've certainly seen people get better with this medication. Similarly with Vibrid, vilazodone. No studies, but up to 60 milligrams a day. I actually did a study with levetiracetam, an anti-epileptic, and we found slightly more than half of patients improved with it. And even though we have a positive study, I do think it's an option. I think it's a less good option, certainly less good option than switching to another SSRI or trying clomipramine. I actually think it's a less good option than these, but it does remain an option if something else hasn't worked. And just to remember that certain other symptoms may modify your medication approach. So if you have bipolar I disorder, if you have true manic episodes, you need a mood stabilizer before you try an SRI. But remember, the neuroleptics are mood stabilizers, so aripiprazole, for example. And for patients who've had very severe manic episodes in the past, I might put them on 2 mood stabilizers before using an SRI. I mention this because I think there is a myth out there that if you have bipolar disorder, you cannot use an SRI. That is not accurate. You can. You just, if necessary. You might want to try CBT first, but if that's not effective, you can certainly use an SRI as long as you are on 1 or maybe even 2 mood stabilizers first, so the SRIs don't make you manic, which is not that common, but it could happen. If you have very severe anxiety, you could consider a benzodiazepine like lorazepam or clonazepam. If you do not have a history of alcohol or drug abuse, and if BDD medications are not sufficient, because The medications I've already discussed tend to be helpful for anxiety. SRIs are good for anxiety. They tend not to work right away for anxiety, but over time they do. The neuroleptics can be very good for anxiety, buspirone. So you may not necessarily need a benzodiazepine, but just it can be helpful for selected patients. Then if you have other co-occurring disorders, you may need additional treatment, for example, attention deficit disorder. Although interestingly, I find some people who come to me with the diagnosis of ADD actually do have it, but some of them really don't. It's just that their attentional problems are actually due to the BDD, because BDD thoughts can be very distracting, especially if you're thinking about your appearance for hours a day. And depression can also affect your concentration and your memory in a very negative way. Those are key symptoms of depression. So sometimes, if we're not sure the person really has ADD, we'll get the depression treated first and the OCD if it's present and the BDD treated, and then we'll see, well, how's your focus and concentration now? And then see if they need additional treatment for ADD. But the main thing is that treatment needs to be tailored to you. So how long to continue effective medication? This also is very individualized. I think you really need to talk with your prescribing clinician about the best choice for you. My general recommendation is to continue effective medication at the same dose for at least 3 to 4 years. That may seem like a long time, but the time goes by so quickly. And I just feel give yourself a good number of years to feel good, to enjoy your life, to do things that you may not have been able to do when your BDD was symptomatic. And I would say for people with very severe BDD who've had hospitalizations for BDD, suicide attempts, or who've tried to come off medication in the past, especially if they've tried to come off of it multiple times and their symptoms have gotten worse, I recommend longer, and for some people, even lifelong treatment. But again, this needs to be individualized to you, and there are pros and cons of continuing versus not. I have no concern at all about continuing the SRIs for decades and for forever. Most of them, and again, I tend to use fluoxetine, sertraline, escitalopram. These are very safe medications, and I think especially if you fall into this group, the benefits of continuing the medication almost always outweigh any disadvantages. Now, the neuroleptics do have some possible side effects. So I think you need to do some blood monitoring from time to time. You could consider tapering them after a couple of years perhaps, but not necessarily. And so again, I think you and your doctor have to weigh the pros and the cons for you. I think if you've been very, very severely ill, I think, maybe better just to stay on these over the longer term with monitoring. But again, it's a very individualized decision. If you do decide to stop the medicine, please decide with your doctor and plan it together. I really recommend that you not just stop the medicine by yourself one day. I would do it at a stress-free time when there are not a lot of major life changes. I think a lot of stress might possibly increase risk of relapse. Do a very slow taper over many, many months. It's not a good idea to suddenly stop the medication one day. And relapse is possible. So in a study that Dr. Sabina and Wilhelm and I did, which I mentioned previously, where we switched responders to escitalopram to switch to placebo or had them continue on the medication for another 6 months, the relapse rate over 6 months was about 40%. So we only went out to 6 months. We're not sure what happens after that point, but so a majority of people did not relapse, but 40% did. Now, they didn't necessarily go back. Their symptoms did not necessarily get as bad as before they went on the medicine, but their symptoms worsened by at least 30% or so. So you do need to have a plan and be in close touch with your doctor during the period when you're coming off the medicine, if you're coming off the medication. But again, for SRIs, I think it's fine to just stay on them over the longer term. So a few medication myths and facts. Some that I've heard: I should be able to get better on my own. Taking medication means I'm weak. Well, BDD is really no different than any other medical disorder, like diabetes or anything else. And when you try medication, you're making a very rational choice and you're taking charge of your symptoms. There are a lot of myths about SRIs out on the internet, so you have to be very careful with what you read. The reality is that most people tolerate SSRIs very well. In our escitalopram study, only 4 of 100 people had to stop it because of side effects, only 4%. And in the second part of that same study, when people had been on the medicine longer, and half were now on the escitalopram and half were on a sugar pill, people on the placebo sugar pill reported more physical symptoms than people on the medication. And they didn't know what they were on, and we didn't either. So there was no bias there, you know, in terms of thinking, oh, I'm taking the medicine, I must be getting side effects. So it's a very, from a scientific perspective, it's a good way to assess this because it was so-called double-blind. We didn't know, and the patients didn't know. So there were actually fewer physical symptoms reported. In these studies, you have to write down every physical symptom that someone gets during your study, whether it's related to the medicine or not, and sometimes it's hard to tell. So people on the medication reported fewer physical symptoms than those taking placebo. So I think especially over time, these medications tend to be very well tolerated, usually. SRIs and other BDD medications for BDD, the core medications I talked about, are not addictive or habit-forming. And they're probably good for your brain health. They are good for your brain health, and they're probably also good for your physical health. For example, they normalize abnormal brain activity. They're neuroprotective. They stimulate the growth of new brain cells. They may decrease stress hormones. They may reduce the risk of certain cancers. This is an area of active research study, investigation. They're anti-inflammatory, which is good for your body in so many ways. Now, possible side effects, it's possible that you will get side effects. I wouldn't expect it, but it's possible. So weight gain is very unlikely with the SSRIs, the selective serotonin reuptake inhibitors. So I would start with one of those rather than the SRI clomipramine, which is somewhat more likely to cause weight gain, but not necessarily, and most people don't gain weight on it. If you're going to add a neuroleptic onto your SSRI, if the SSRI alone doesn't work well enough, aripiprazole is a good choice for so many reasons, and I so seldom see weight gain, especially in adults. Now, there are a lot of medications in that class of medications, and some of them are more likely to cause weight gain, not necessarily, but they can. But aripiprazole is unlikely. Lurasidone was on one of the slides. That's very unlikely. So I wouldn't let fear of weight gain prevent you from trying one of these medications. It's unusual for that to occur on some of these newer neuroleptics. Healthy diet and exercise is always helpful. Sexual side effects can occur. In this case, I think you would want to use an SRI other than paroxetine or clomipramine because they may be a little bit more common on those meds than on the other SSRIs. They often resolve with time. Most of my patients find that if you can be patient, with weeks, sometimes months, sometimes up to 6 months, occasionally a little longer, they often just get better and go away. And if needed, certain medications can help. I would also say that just as often, the sexual side effects maybe occur in about 20% of people. That's, you see different numbers in different studies depending on how the questions were asked. But again, I find it usually gets better if you're just patient. But I find that probably about 20% of my patients find that on one of these medications, their sexual functioning improves because BDD can interfere with sexual function. All the anxiety and having your body seen and depression can really interfere with sexual functioning. So when these medications improve the BDD and the depression, your sexual functioning and your interest can actually improve. Nausea occurs maybe 10% of people early on. Usually occurs early on if it's going to occur. Usually improves pretty quickly. It can help if you take your SRI right after a meal. It might help if you split the dose into 2 daily doses rather than taking it all at once. And if needed, certain medications can help. Insomnia, maybe 10 to 15% of people, depends on the specific medication you're using, may resolve with time, not uncommonly. And some people have good energy despite not sleeping quite as well. If it doesn't resolve on its own, you can try things like sleep hygiene, which are behavioral strategies to improve sleep, mindfulness meditation, CBT for insomnia, or certain medications can help. Fatigue, maybe 10-15%. It depends on the med, it depends on the study, what number you get, but I find that also often resolves with time, and if this happens, taking the medication at bedtime can help and can actually help you sleep better. Sweating, maybe about 10% of people. My patients, I rarely hear about it from my own patients, but the studies would suggest maybe in that range. That too can resolve with time, and if not, certain medications may help. So most people get no side effects. It's often hard to figure out if a physical symptom is actually a side effect. Don't assume that it is. Maybe it is, maybe it isn't. Get some nausea, maybe it's some bad food you ate, maybe it is the medication. It's sometimes hard to know. If people tell me they think they're sensitive to medicines, they've had a lot, side effects in the past, we'll start with a lower dose than usual, sometimes a very, very teeny dose. And I find even in people in whom we start with a teeny dose because they think they're sensitive or we see that they are sensitive, we can usually almost always get up to those higher doses if needed. We just need to start out at a lower dose and go a bit more slowly. If side effects occur, they're often tolerable and often get better with time. If not, certain remedies can help. Don't let fear of side effects prevent you from getting well. And I encourage you to give medication a good try and see what the pros and cons are for you after an adequate trial. I wouldn't base it on what you read online or what happened with a friend. Weigh the pros and cons for you as an individual, and then decide if you want to keep taking it. If it's not helpful, then you wouldn't want to, and most people get better and do want to continue. We don't know if these treatments work for BDD. There are no published research studies, so psychedelics, transcranial magnetic stimulation, no studies in BDD. Might deep TMS work? Maybe. There's some evidence that this works in OCD. There's one case report on deep brain stimulation that was effective, stimulating a part of the brain that's often stimulated successfully in OCD, but we don't have studies. We don't have studies of any of these treatments, of other types of neurostimulation or brain surgeries, such as a capsulotomy or a cingulotomy. But medication and CBT work for most people if they're well implemented. So I find it's very rare that we'd even need to have to consider one of these alternative treatments. So just a reminder, I showed you the half top of this slide earlier, our approaches for mild, moderate, and severe BDD. And what's new here is adjunctive treatments. These are add-on treatments, not standalone for BDD, but things I recommend for my patients, if I think any of them might be helpful for a specific patient, that I think can really get them feeling even somewhat better. So added to the CBT and or the medication. Bright light therapy, if they have some depressive symptoms. These are specialized bright lights that you sit in front of every morning when you wake up, and they can improve mood and energy, even during the summertime. Sleep hygiene or CBT for sleep insomnia makes everything worse. A lot of people with BDD don't sleep well. They're anxious. They might be up during the middle of the night checking the mirror. And so trying to get sleep better, I think, is important. So I often work on that with my patients. And of course, the medications we've talked about can help sleep. Sometimes people with BDD are typically very anxious and not sleeping well, but often they're drinking a lot of caffeine, which can worsen both insomnia and anxiety. So we often work on trying to decrease that a bit, or some people will even stop it, and that can help. Dialectical behavior therapy, DBT, that's not a first-line treatment for BDD. The first lines are the cognitive-behavioral therapy and the serotonin reuptake inhibitors, but sometimes people benefit from having some of these techniques added to their CBT treatment. Exercise is good for everyone. It's good for your physical health. It's good for your brain health. It can elevate your mood, so always recommended. The Mediterranean diet can improve mood symptoms. Again, I wouldn't treat BDD just with the Mediterranean diet, but as an add-on, it's one more thing, like the bright light therapy, like getting your sleep better, that may help your overall sense of well-being and help you tolerate BDD better. Some people benefit from an additional supportive therapy to talk about life problems, this kind of talk therapy. I think generally if you're going to do that, you want a different therapist providing the cognitive behavioral therapy and the supportive therapy. But if you want a talk therapy, there's no reason you can't do that with a separate therapist if there's a lot of stress in your life or a lot of issues you need to work on. And then mindfulness is something I recommend for everybody to learn, whether they have BDD or not. And again, this can be a helpful add-on to medication and or CBT for BDD. So in summary, BDD is common, it's under-recognized, it's often severe. Most people substantially improve with the right medication, and it can be life-saving. SRIs, also called SSRIs, often at high doses, are the first choice medication, and certain other medications can also help, as we discussed. Just remember, you need to take the right medication at the right dose every day for a long enough time to give it a good try, and most people tolerate the medication well. Side effects, if they occur, often occur earlier in treatment, and they often get better with time. So give these recommended treatments a try. You have nothing to lose, everything to gain, and maintain hope, because most people with BDD can get better. So thank you very much. And I think we have a little time. I'm happy to take a few questions.